Now, last month, world leaders, of course, endorsed the second UN Political Declaration on Universal Health Coverage, UHC. This reiterates the universal right to health. It was, as ever, a time of really intense advocacy at the local level, national level, but also for global health organizations like UICC, like the NCD Alliance, and others who are really trying to put cancer high on the global health agenda right now. Now, in this panel, we're hoping to hear from all of you about what your countries are then doing in prioritizing universal health coverage programs. I wonder if, Minister Butera, if I can come to you first and ask you about the takeaways from all the discussions in New York. I don't know if you were there personally yourself, but from Rwanda's perspective, how did the political declaration and the fallout from that feel for you?
Thank you, and thank you for inviting us. It's an honor to join you today. So universal health coverage for Rwanda, we approach it as having health as a human right. So we have 95% of our population covered by health insurance, and of those, more than 90% are community-based health insurance. And with that, we strengthened, first of all, our primary health care. So we have a large network of community health workers that deliver preventive services to the entire communities. And then we have health centers where we start seeing screenings. And you can also talk about, particularly as we're discussing about cancer, a lot of screening is done at the community level. A lot of preventive activities are done there. We screen for cervical cancer at the community level. And then as you go upscale to the level of hospitals, you start seeing treatment, and to the tertiary centers, you start seeing specialized integrated treatment like cancer, where you have a Rwanda Cancer Center that provides diagnosis, treatment, and cure, as well as the Butaro Cancer Center. So we approach it holistically from the level of a community, everyone getting equal access to all the services that they need. The second thing is the health financing part of it. Rwanda spends 15% of its GDP on healthcare financing. So we...
How much was that, sorry?
15%, 1-5, which respects the Abuja Declaration on health financing. So we put quite a bit of financing so that we allow our communities to be healthy, because we believe that healthy communities will equip the country to be able to get to the economic and social transformation that we want. So health is a prerequisite, and we really invest in it. So financing, access, and equity for everyone.
In terms of law, what are the Rwandan commitments to universal health coverage?
We are signatory of the New York Declaration that we just had at UN General Assembly. Already in terms of financing, we're doing that. We are increasing. What we're doing now is expanding now the package of services. For instance, I can give that we are putting chemotherapy as part of the essential medicine list that can be accessible to all the communities. Mm-hmm. So what we're doing, generally the principle is that you have universal health coverage as a right in the country. Now what you're trying to do is to expand the number of services that can be done.
And you mentioned chemotherapy there, but are there other cancer services that are in the pipeline for inclusion as well?
So one, if you want to go diagnosis first, so we do, or even downstream prevention. We do a lot of preventive activities that are accessible to everyone. Screening, we do screening and have it accessed to everyone in the country. Treatment, chemo, we are including it. Radiotherapy, we have Rwanda Cancer Center that is equipped with 2 linear accelerators that provide the modern radiotherapy services to the community, and all that is part of our basic package services.
And what about the Rwanda's priorities as far as just cancer control is concerned going forward?
Yes, so again, prevention first is the key one here, and we approach it in a One Health approach. So every last Saturday of the month, we have community activities where we clean the environment. We do plant a lot of trees. We were talking about in the previous session, the intersection between climate and health, which is quite relatable to us. So we really protect the environment so that we plant trees and the planet gets safer. Second thing is that so the first and the last and the third Sundays of the month, we close all the main arteries of the cities, what we call the car-free days, encourage people to walk, to jog, to cycle, so that you prevent NCDs and oncology as well. At the same time, we avail services of screening during that time. We screen for non-communicable diseases. You know that you have, for certain non-communicable diseases, you incur a risk of cancer. Obesity is a leading factor of cancer. We encourage people not to smoke. As a result of that, we've seen a decline of 7% in tobacco prevalence in the country. In 2012, we were at 13%. We are now at 5%. We are having a campaign against less drinking, like Her Excellency First Lady talked about. So all those combined factors on the level of prevention, so that you have healthy people, is done that way. Screening, we do massively screen. Interventions, we have more than 90% of our girls who are protected against HPV. Right now, we are also doing a service so that those who are playing the catch-up, we are screening them aggressively. We are using HPV DNA testing so that you're able to detect those high-risk cancers, HPV 16 and 18, so that you do proper follow-up for them. And that's towards the elimination of cervical cancer, that we have a target towards 2030 to eliminate cervical cancer. So I'm just using the cervical cancer example as a complete package from prevention, screening, diagnosis, treatment, until palliative care, but it's applicable across the board. Breast cancer is the same, where we have integrated services. We have community screening, where community health workers go in the community and teach ladies how to do self-palpation. You have screening at the level of a facility. You have access to mammogram. You have access to histopathology. Diagnosis is happening there. We are doing immunohistochemistry for our population as well. We do combine surgical oncology and tumor boards at the level of the hospitals, where the pathologist, the radiologist, the surgeon, the oncologist do the treatment plan together so that you have better outcomes. Prostate cancer is the same, colon, gastric, etc. So we're really strengthening our care in that. And another important component that we're doing now is to add the training part of it. So we are going to launch this year a fellowship in medical oncology with partners. Some of them are in the room. I saw Dr. Dayo from Brigham, who's here, who's helping us setting that. Last year we started, because cervical cancer is one of our priority, we have a fellowship of gyne oncology that we launched next year, so that you're training people how to take care of complex cases. So all that, the combination of all those factors are what are the center of universal health coverage, and the person is at the center.
Well, I mean, it all sounds really, really exciting. And obviously, you have a fantastic advocate in your country as well, with the First Lady, who we were so lucky to hear from earlier as well. Thank you very much, Ivan Butera. Let me turn to Qatar now, and Dr. Al-Thani. I understand that Qatar has recently launched a national cancer plan. Tell us about it and what your ambitions are over the course of the next couple of years.
Thank you, and I thank my friend from Rwanda. Thank you so much. I agree with all this wisdom that you mentioned. In brief, in Qatar, the main thing in our action plan that helped Qatar to grow is a strong leadership. You know, for some time, the health was led by the Supreme Council, the Prince himself when he was heir apparent, and led by Her Highness, the First Lady, Sheikha Moza. And this helped us to put everybody together. We connected the dots. It's very important to connect the dots and put everyone in the system on the same table. And this is the third action plan for us. We did strategies since 2011. And by following up, the secret to follow up, many people make strategies, but 92% of the strategies fail because there's no proper follow-up. So it's very important to dedicate a team for the follow-up. We can say that Qatar is, I think, as Dr. mentioned, Dr. Ammar, we are one of the best countries in universal coverage because Qatar have a low tolerance to leave somebody behind. You cannot leave anybody behind. It's a small country, and if any person is not getting the right treatment, everybody in the country will know through the family and the friends and society. So there's a pressure always to take care about every case. So universal coverage is always assured, but with the generosity of the government, we need always to take effective ways to save more lives. And this is what end by Qatar have the highest life expectancy in the region, and to give them more lives, more years to live. The second thing is efficiency. Now, we are generous, but we need to find ways to lower the cost. So first, we send cases sometimes to abroad, but then we master the system and make it better in Qatar. One of the core competency of Qatar that we have the system working together, the prevention, the primary health care, and the secondary and tertiary care and the society, cancer society, is with us. So this helps us that the patient, before he become a patient, he knows that there is a clear journey for him and will be supported and not left alone. So this help us to invest more in national screening. So we have now breast screening for women and colon cancer screening for men. And it's working, growing every day because the trust increasing. People have stigma from this and they are worried. But by proper education, things are becoming even better.
Have you changed course from previous cancer strategies as well?
Yes. First, the strategies start to be very ambitious, and then you cannot do everything in one time. So you make better action plans focused on things that you can do and to move forward. The other thing, always the challenge that when you said, I want to make cancer, you will have many bottlenecks. When you say, I will check everyone, you don't have the system suddenly to check everyone at the same time. And then primary healthcare will do their role excellently, but they will refer many people to the secondary care, which the secondary cannot help them all. And you need to repeat the definition to get the right number that need to be tested, to get the right yield behind this one. The other thing that we are not accepting in Qatar, low quality treatment. Everybody should have the same treatment. There's no cheaper treatment. Somebody will pay for it, the charity or something, but everybody will get everything they need. And the other thing, increasing the cost in Qatar, and we are clarifying this for the cabinet, is that everybody is surviving. We have 88% surviving for breast cancer. You need to follow them up. So you did their great for their lives. They are living, but you need to follow them up to keep the quality on the long term. So this is increasing the cost, but increasing the value. And this is one of the very things that people love in Qatar after the safety and security is universal coverage. People maybe doesn't have the highest salaries, but they are happy that they will not left behind by the system and supporting the family behind the people.
Amar's already touched on the financing. How do you finance cancer services in Qatar then? How is it paid for?
Okay, first, mainly is the government. Mainly the government is dedicated for health because we have invested part of our oil and gas, is for education and health. And this has helped us a lot. Part of the vision that was achieved very well now, it was the long-term vision in Qatar for 6 years to educate people, all people. So when we have this vision, we had the people to support us. So the government trusts that the people in the health system will do the right jobs and they are ready to give. Plus, we have fundraising happen through our cancer society. So anything needed for people that the government exactly, it's not part of health, supporting the people after the treatment, the society will take care about them, and this will have the generosity of the society to support these people. So you can find everywhere places to pay for charity for this one. And it's a priority in Qatar to take care of it. Other money goes outside Qatar later.
So it's continuous care, as you were just outlining. As far as universal health coverage specifically is concerned, is there a commitment from the country towards that? An actual in-law commitment?
Yes, a strong commitment. It's like I told you, we have zero tolerance. We cannot accept that anybody left behind in health in Qatar. But because we are always paying for that, we try to find ways to make it more effective and more efficient.
Thank you very much. Let's turn to the Philippines now, and welcome to you, Dr. Balboa. Back in 2019, you introduced a universal health coverage law in your country. How did that come about, and talk us through the sort of the achievements of that and what it's meant?
Yes, well, thank you very much, and I'm happy to be part of this summit. Yes, as mentioned, in 2019, we had the Universal Health Care Act that was enacted, and of course, it is aimed at providing, ensuring access to equitable health and quality health with financial risk protection. Okay, and after about 5 years of implementation, we now have a lot of improvements in our healthcare delivery system. One is that we're able to improve access. We were able to provide or establish and upgrade several primary care facilities, especially in communities that are really poor and underserved. And we have also expanded our field health insurance coverage. We now have 93% coverage, and the remaining are enrolled at point of care. And then also we were able to reduce the out-of-pocket expenditure of the patients. One strategy is coming up with maximum retail price that had regulated and reduced the prices of essential medicines to an average of 40% to as high as 93%. Okay, and then of course we have expanded our PhilHealth coverage benefit packages and with the several financing mechanisms that we have supporting universal health care. Of course, we're able to improve a lot.
And specifically about cancer care, where does that fit into the UHC?
Yes. With the increase in budget for UHC, this is translated also into a better focus on cancer program. With the present administration, we have provided a lot of help to the cancer patients with the improvement of primary care packages. No, we have improved access with the establishment of several health facilities that provides screening, detection and treatment to these cancer patients. Of course, are able to help them a lot. And also, when before we were focusing more on providing treatment medicines, now we are shifting more on prevention and screening to be able to really improve the survivability of these patients.
And you mentioned about the current administrations. It's a different administration since the law was first introduced. Is there more of an emphasis or more momentum now with this administration than with the past?
Yes, we have more funding support now for the cancer control and prevention program. And because we have very supportive legislators from the Congress and Senate. Actually, they're the ones pushing for more budget for the cancer prevention program. And that is why we are also increasing more benefits to our patients so that, of course, we can serve them more.
And you touched on the financing of it, but talk us through the financing model that you work with in the Philippines.
Yes.
Has it changed a lot?
Well, for UHC, we have two types of financing. For the population-based services, these are primarily coming from the national government through the Department of Health. And but for the individually based services, this is mainly from prepayment mechanisms, social insurance, private insurance, and the HMOs. And of course, as to the source of funding, majority of this is coming from our sin tax collection. And then we also have government share coming from our games and amusement or corporations. And then we have the annual budget or appropriation that is being determined by Congress. And then we have the membership premium for PhilHealth and national subsidy. And of course, some supplemental funding from grants and loans.
I can see Amma nodding along there. You obviously approve of what you're hearing. And specific to the Philippines, we're talking about a large country, thousands of islands, heavily populated urban areas as well. How difficult or how specific are the challenges for you then in achieving health for all?
You're referring to the challenges? Okay, yeah, we have a lot of challenges in the Philippines. First and foremost, our geography. We are composed of more than 7,000 islands. And then, of course, there are still a lot who are really poor. So we have to solve these gaps. For the poor, of course, they have limited access to health services. They have their manpower is limited. And then, of course, the distribution of the services is difficult because of the geography. So we have to solve these gaps. Now, first, as I've said, we have improved the primary care services that would provide basic services to the community. And then second is in areas where we cannot construct fixed facilities, we are having the mobile health clinics, okay? And with this, we're able to reach even the most remote areas, and these mobile facilities will have with them not just the ordinary consultation and provision of medicines, but more importantly, screening, like for cancer. And we also use telemedicine, okay? And then, well, for the manpower, the deployment of of health workers coming from the national government to help the poor LGUs, well, that's just a stopgap. But the more sustainable approach is we provide scholarship to the deserving members or students of the community, so that after they graduate, they are required to go on return service to the community, so they can serve their fellow men. And then, of course, we also have, improving digital infrastructure, as I've said, telemedicine. And these primary care facilities that we have increased in number, we accredit the primary care providers, so with the facilities, and we organize them into networks, okay? And this would also include the different levels of facilities from level 1, level 2, level 3, with an apex hospital where referrals could be done, such that, in areas, say a province, they already have the entire services there, no need to go to the urban areas. And this is within a certain jurisdiction, and this has really improved a lot. We have actually 72 right now UHC integration sites, which are more advanced in the implementation of UHC. And this is 72 out of 82 provinces. So we are, of course, near to achieving UHC in all these provinces that we have.
Well, thank you very much, Gloria, for that very thorough answer there. I want to put a final question to all of you, really. I mentioned at the beginning about the political declaration in New York last month. It involved a 1% increase in health spending, which I think to many seemed quite unambitious, let's say. Amma, let me come to you first. What do you think is stopping governments from investing and increasing financing for UHC?
So first, there is no magic solution today, because we know if you want to increase the total health expenditure, you have to act on two. Either the GDP, so you have a good economic growth that could contribute to the governmental share, or the second thing is to increase the income from taxes, and this is where the role and the people in law could help in determining the framework, the legal framework to get access to those funding. But still, despite all of this, in the post-COVID era, most of the member countries have suffered. So they have invested a lot during the COVID. So they are challenged by the limited headroom or the limited fiscal space that they have. So the only way is to get out of their context and seeking support from, I'm talking about for sure, about the listed developed countries or the low-income countries in economic terms, or the lower middle-income countries. Those which are from the highest middle-income countries and the high-income countries could deal by reaching out to the private sector. So the public-private partnership is a very good tool, actually. We have a good example from Turkey, from mainly Turkey, actually, which is leading in our member country, and other countries like Uzbekistan, which is trying to do so. This is one. And the second also, to get access to some line of financing from private bank to support that. But still, it's very heavy. The government role shall be there. It has to increase its support, because the cost of equipment and the cost of infrastructure and the cost of drugs for treating cancer is very huge. So if there is no private or social security system, if there is no governmental support like in Qatar, so we will never finish with the cancer. Thank you.
Yes, we heard so much yesterday. Oh, there we are. I'm back again. I heard a lot yesterday about the importance of not looking at it so much as a cost, but as an investment as well. And Ivan, to that point, then what do you think is holding not necessarily yours, but like other governments back from looking at this as an investment rather than a cost?
I think leadership and political commitment has to be at the center of it. We're proud to have in Rwanda that leadership that has been present since the get-go. As a result of that, actually, our president is the champion of health financing on the continent at the African Union. So Rwanda has consistently, in the last 10 years, removed the COVID period, growing at 7% plus of GDP. And we are slated to return to that growth from this year. And that shows you, if you allocate 15%, you have 15% that's growing every year. But that's not the end of it. I think, what do you do with that? I'll just use one example. We were talking about how the costs of drugs are really expensive, but we want to close the loop where we are really investing in manufacturing of drugs and vaccines on the continent. And with that, you cannot do it alone. We are in a partnership with BioNTech, which is planned to launch the first mRNA-based plant in Africa that is going to be launched in December in Kigali. And with that, you're doing two choices. One, you're partnering with private, but you're also investing in the technologies of the future. mRNA is going to revolutionize medicine for vaccines, but also for treatment. We listened in the first part of the talks today, no cancer is similar to another. And BioNTech, with us, we are investing in precision therapy so that the money that you're investing in the lives of the people, you're investing it as efficiently as you can. So we've started a journey from prevention, diagnosis, screening. Now we are going towards precision therapy that is backed by universal health coverage with a strong political commitment.
Thank you, Ivan. And I'm back. Okay, there we go. It was the same question, really, as to if there's only a 1% commitment that we got in New York last month, then how do we go about encouraging countries and governments, really, to invest in their populations, invest in their people?
Yes, thank you. In a brief, the most important thing for the cabinet always to be convinced that they should support this, because many voices in the cabinet or the parliament say they should go to the private sector and to go to health insurance. And we are not responsible for it. And here you should prepare a proper technical paper saying how much this investment, the money will come back. We know very well that $1 in prevention is equal to $7 to $12. It come back to you $7 to $12, a big high investment. But the government sometimes, when they need the money, they don't listen to this. You need to clarify for them the importance of this investment on the long term that make it a healthier country, even in productivity. Is one thing, the challenge for the cabinet. They are waiting not to pay. The second thing is that you should have a clear plan how much you are reducing the cost and you are getting value from this 1% on the real life, like equal to 2 or 3% to get more things. Third, it should be alignment and fairness between the system, who should take the money. Because sometimes you get 1%, it can be more valuable and preventive, and it ends for another tertiary care things that are not priority for now. So I hope that in this planning with the government and the people, this investment is the right of the people. If you go back, first people need to live and then to have education and then work. And now health is becoming the rights, real rights, and we should not miss it for any other priority. Thank you.
Thank you very, very much. We have to leave it there because we have just run out of time, but it's been fascinating hearing from all of you. Could everyone in the audience please join me in thanking our guests, Mohammed, Amar, Doria, and Ivan. Thank you very, very much.